I'm Dr. Deepak Talwar, Director Chair, Metro Center for Respiratory Diseases, Noida. Now I'll discuss management of acute exacerbations of bronchial asthma. And first thing would be to understand what is an acute exacerbation. Acute exacerbation is just an acute flare-up or worsening of symptoms of patients and their lung functions, which has been happening either acutely or subacutely in the last couple of days to weeks prior to coming to us. The management of worsening asthma is perhaps considered as a continuum, because these patients already have some kind of an asthma action plan where if their asthma symptoms worsen, they know how to step up their treatment. So despite stepping up their treatment, if they do not respond, they either are managed at the primary care or they need to be either seen in the emergency room or admitted in the hospital. And after this exacerbation, it is very important because they are at risk of further exacerbations that need to be followed up closely. Once a patient comes under asthma exacerbation, it is our duty to have a clinical examination and assessment of severity of exacerbation, which depends upon level of consciousness, whether the patient can speak in complete sentences or phrases or words or not. Look at their vitals like pulse, blood pressure and respiratory rates, whether there are audible wheezes or not, use of accessory muscles, how much anxious and sweating and profuse tachycardias are there or not, oxygen saturation and peak expiratory flow rate. It is important to remember that a patient who's got a severe exacerbation may have no wheezes in the chest, and they classically may present with what is called as silent chest. The severity of asthma exacerbations are divided into mild, moderate and severe depending upon various features on clinical and physical examination. If breathlessness is on walking, it is a mild one. If it is on simple talking, it is moderate one. And if it is even at rest, then the patient is actually a severe exacerbation. If patient can complete only the sentences, then it is good. Patient is in mild exacerbation. If he has pauses and does in phrases, it is called moderate exacerbation. If only few words can come at a time, it is a severe exacerbation. Generally, accessory muscles of respiration are in use in moderate to severe exacerbations, and pulsus paradoxicus is also significant in moderate to severe exacerbation. Peak flow rates are less than 50% in severe exacerbations and more than 80% or 80% in mild exacerbations, 50 to 80% in moderate exacerbations. Room air saturations are compromised in severe exacerbations where it is less than 91%. However, even if it is 92%, it is not normal and would be indicating something like moderate exacerbation. Carbon dioxide, if you do an ABG, mild exacerbations will show that there is a normal CO2. In moderate exacerbations, the CO2 will start becoming less. However, if the exacerbation is very severe, then only the PCO2 rises. So what it means is, if you do a ABG in a patient who is suffering from acute exacerbation, if the PCO2 is high, it would mean that the patient is having severe exacerbation and perhaps impending arrest. If they have a low PCO2, then still this is showing that patient is hyperventilating and is somehow able to manage the carbon dioxide washout, and hence is not in mild to moderate exacerbation only. The features of life-threatening asthma need to be identified because these patients need to be sent into the intensive care unit immediately. These are the patients who have got altered conscious level, they are exhausted, they have poor respiratory effort, they are cyanosed, they have silent chest, peak flows are less than 33%, and they are in respiratory failure with saturation of less than 92% of protected. Some of the patients can have red flags, which is basically a risk factor for asthma-related death. These should be quickly identified and again sent to hospital or for emergency care into the intensive care unit. And such are the patients who have a past history of near fatal asthma, past history of hospitalizations or emergency care in last 1 year, who are not using any medications or are not adherent to the medications, particularly inhaled corticosteroids, who have recently stopped using oral corticosteroids, who are abusing short-acting beta-2 agonists by using it repeatedly, where like they are using 1 canister in a month. They have a lack of asthma action plan, and of course history of psychiatric and psychological problems. Some patients with confirmed food allergy and asthma like peanut allergy or insect allergy are also at risk for asthma related death and should be quickly referred to hospital for further management. Some of the asthma exacerbations, like mild exacerbations, can be managed at home, and patients should have a written asthma action plan where, in case they have the symptoms worsening at home, which is mild in nature, can be managed by stepping up the therapy. These patients need to be counseled how to take care of their situation at home, and if it does not resolve, then they need to go and visit the emergency department or get hospitalized depending upon the severity of the disease. Such patients need to be given the advice, which should be in the form of that in case there is a worsening of breathlessness, cough or wheeze, or their symptoms are more during activity and exercise, or they have frequent nocturnal awakenings, or they have their peak flows which have fallen down by 20% from their personal best, they need to use the rescue medication. Rescue medication is salbutamol, where 4 puffs can be given every 20 minutes up to 1 hour. So they can use 3 times 4 puffs up to 1 hour, and if they do not respond to that, then obviously they need to start with oral corticosteroids and immediately report to the doctor. If they become alright with that, then they need to monitor their peak flows, and if they are alright, they continue to monitor the peak flow, and if they dip again or there is worsening of symptoms, they can again use their rescue medication. However, if they use the rescue medication every day, then they need to go back to their doctor to see, because their asthma has become uncontrolled, which is not being managed on the lines of mild exacerbation of asthma at home. Established therapies for management of asthma exacerbation in the emergency room or the hospital are oxygen, steroids, short-acting beta-2 agonist, and short-acting anticholinergics. However, in the ICU, sometimes rescue therapies like helium and oxygen mixture, Heliox, can be given, or the patients can be tried on non-invasive ventilation, and if everything else fails, patients are to be intubated and put on to invasive mechanical ventilation. Steroids are again the mainstay of not only the chronic stable asthma but also of all acute exacerbation management of asthmatic patients. It is equally effective whether you use intravenous or orally. However, in acute exacerbations, we need to use systemic corticosteroids rather than inhaled corticosteroids. But all steroids, whether given intravenously or orally, will take few hours to get the peak onset of action. Recommended dose is 1 milligram per kilogram of the dose, and then it can be repeated at 4 to 6 hours depending upon the condition of the patients. The generally regimens will require them to be taken for 5 to 7 days, and if the steroids are not given for more than 7 days, they can be stopped altogether and there is no need to taper them. However, if the patient have continued oral steroids or intravenous steroids for more than 10 days, they need to taper it in the next 3 weeks. Beta-2 agonists are the most frequent bronchodilators used to manage the asthma exacerbation to relieve the symptoms of the patients, and they are available again in either inhaled, oral or subcutaneous or intravenous forms, but here all of them are used in the inhaled therapy only. You can use either a meter dose inhaler to deliver it with spacer, or you use a nebulizer, because the effect is nearly the same. However, the nebulizers give more relief to the patients because they are more comfortable in using them, and also it can be given on a long period of time repeatedly to these patients. Medications, as far as beta-2 agonist dose is concerned, it is dosed to the effect. So till the time patient develops side effects, you can keep using it every 20 minutes, like initially for 3 times, later on every 2 hours. If the patient develops side effects, you need to tone down the dose of beta-2 agonist, but sometimes even continuous nebulization of beta-2 agonist can be given up to 1 hour in these patients to quickly control the asthma exacerbation. The delivery, as I said, is preferably nebulizers. Jet nebulizers are the ones which are used. Jet nebulizers take longer time. We have mesh nebulizers available which take within 2 to 5 minutes to nebulize the same amount of drug, and ultrasonic nebulizers take even few seconds, 30 seconds to 1 minute to completely nebulize the drug. They are particularly useful in children. However, in adults we use either jet nebulizers or mesh nebulizers, and we can also use a MDI with a spacer. So if the patient does not have a nebulizer at home, or you do not have it on a clinic, you can immediately use a PMDI with a spacer and give 4 to 6 puffs immediately and go up to 10 puffs to control the asthma symptoms of the patient before sending the patient to the emergency room for the further management. Nebulizer is something very simple to use because you cannot go wrong, whereas the other all devices need the technique to be correct. So in such situations where you are not clear whether patient can use it appropriately or not, it is always better to use a nebulizer, because you rarely go wrong there. Whether you use face masks or a mouthpiece when you are using a nebulizer for controlling the symptoms of the patient in acute exacerbations, you can use face mask or you can use mouthpiece depending upon what is more comfortable. If the patient is more sicker, then face masks are better. If the patients are less sick, then mouthpiece is more comfortable to them, and you can use any drug, whether you are using inhaled corticosteroids, anticholinergics or short-acting beta-2 agonist. Continuous salbutamol nebulization can be given where 0.5 mg per kilogram per hour is given with the total dose of 10 to 16 mg per hour. However, toxicity like hypokalemia, agitation, tremors, tachycardia, ventricular arrhythmias and hypoxia need to be considered. So patients should be simultaneously also given oxygen, and it should be dosed where the unnecessary side effects are not there, particularly tachycardia and tremors. However, the arrhythmias can always be checked on the ventilatory monitors, and of course the potassium level needs to be checked in these patients. Levosalbutamol has a better toxicity profile, and if you need to use it, is better you use a continuous levosalbutamol rather than salbutamol, which has a higher toxicity potential. Anticholinergics are also being used to manage the acute exacerbations, and here we can use ipratropium. It has been shown that it causes about 10% improvement in PEF, and 3 repeated dosages can be used in emergency room, and the peak flows can be checked to see. On the routine, when the patient is admitted or at home, it can be dosed at 6 hours and then continue till the time the patient is improved or better. Theophylline is rarely used these days to manage exacerbations of asthma. Mostly it is reserved for status asthmatics where all other drugs are not working, and here it has been shown that it decreases the need for intubation and mechanical ventilation at the cost of more nausea, vomiting and gastrointestinal side effects. Since it's a toxic drug, it should be only given under careful supervision and in the hospitals. Preferably those patients who have failed on the therapy are at the verge of getting on to mechanical ventilation. So such therapies should be perhaps used in the intensive care unit only. Magnesium sulfate, which was used about a decade ago very significantly in managing severe asthma patients, 2 gram IV stat is used to be given, diluted in 50 ml to be given over 15 minutes. And there is only single dose effect of magnesium sulfate. There is no role of using magnesium sulfate on 8-hourly dosages. Magnesium sulfate, if it has to work, it will work on a one single injection. And there are certain patients who are very sick with FEV1 of less than 25%. It has been shown to reduce their admission rates and improvement in symptoms. So if the patient comes with an acute asthma attack, the most important thing is to identify whether it is life-threatening or not. The symptoms of life-threatening has already been discussed, like patients cynosed, patients who have got severe respiratory distress, who has got silent chest, who has got an impending cardiorespiratory arrest, and in such sick patients, they need to be given oxygen and nebulization to be shifted into the intensive care unit. If not, then if the patient is mild to moderate, they can be managed even at home or emergency room or the clinic settings, where these patients can talk in phrases, they can sit or even lie down, only the respiratory rate is increased, their accessory muscles are not used much, they have a tachycardia about 100 to 120 pulse, saturation is not normal but between 90 to 95%, and there are more than 50% of their peak expiratory rate flow, which is their best value or predicted value. Such patients are given inhaled short-acting beta-2 agonist. You can use 4 to 10 puffs with this spacer and repeat it every 20 minutes. Also give oral prednisolone at the dose of 1 mg per kilogram body weight and a controlled oxygen to keep their saturations to around 94-95%. On the other hand, if the patient has got severe asthma attack, can't talk in complete sentences or phrases, there are few words, he's agitated, he's sitting upright, very anxious with respiratory rates more than 30, using his accessory muscles, marked tachycardia with pulse of more than 120, oxygen saturation less than 90%, or peak flow less than 50% of predicted or his level best. Such patients need to be transferred to the acute care facility, and when by the time you are transferring this patient, they need to be given short-acting beta-2 agonist. combined with ipratropium bromide, oxygen and systemic steroids. Never send a patient to the hospital before giving steroids, because patient may reach the hospital and get a cardiorespiratory arrest there. So if you have diagnosed a severe exacerbation of asthma, you have a plan of sending the patient to the hospital or the emergency room. At least give this patient a nebulization of short-acting beta-2 agonist, ipratropium bromide, oxygen and oral corticosteroids or IV corticosteroid, whatever is feasible at your clinic, before sending them off to the hospital. Mechanical ventilation is lastly given when those patients who fail on the therapy, where you need to rest these patients for some time, where airway obstruction is relieved over next couple of days, and then they are reversed and extubated. The criteria of discharge once the patients are admitted with acute exacerbation is that the symptoms have improved. They don't need short-acting beta-2 agonists. Their peak flows have come in the range of 60 to 80%. There is no respiratory failure, saturation above 95%, and they can manage the patient at home now. So at the discharge, reliever medications need to be continued, controller medications have to be start up or stepped up, and we need to check their inhaler technique that they will be able to use it or not. If there is any doubt on using the technique in the inhalers, they better to be discharged on nebulizers at home and to be reviewed in 5 to 7 days to see whether they can be shifted back to inhaler or not. First follow-up is very important within 7 days, where you need to see whether the patient is really improving or is deteriorated back. If the patient has deteriorated back, then you need to step up the therapy, even use the oral corticosteroids in such situations. So follow-up after an exacerbation is to look at the patient's exacerbation has subsided, where the lung functions and the symptoms have returned to normal. However, these patients are at increased risk during the recovery phase of the exacerbation. So this is an opportunity which needs to be taken to explain the patient about exacerbations and review their asthma management. And at follow-up, we also need to see that what had actually caused the flare-up so that it doesn't recur. Are there any modifiable risk factors like smoking which can be addressed? If the adherence is the issue, now is the time when we need to talk to the patient to adhere to the therapy. Inhaler technique is to be checked, and again this patient must be given a written asthma plan, where in case of worsening, mild to moderate, they can manage at home before contacting the doctor or reaching the emergency room or the hospital again. So to conclude, although the goal of the regular ICS therapy is that patients should not ever get the exacerbations, but they do get it because of certain trigger factors which have been unidentified or cannot be identified or cannot be managed, like viral respiratory tract infections. Now, some of these patients have got high tendency for exacerbations. They need to be identified because they are at risk to death. Minor exacerbations can be managed at home by stepping up the therapy as well as using the rescue inhalers. Moderate to severe exacerbations require more vigorous management, which is in the form of, again, stepping up these therapy by giving them the reliever medication and oxygen and parenteral steroids. Life-threatening attacks should not lead to any other kind of therapy to be tried, because these patients should be sent straight away to the intensive care unit for admission. But prior to sending them, they must receive oral or parenteral steroids as well as nebulized short-acting beta-2 agonist and anticholinergic drugs with oxygen while they are being transferred to the intensive care unit or sent to the hospital. And once the patient's exacerbation subsides, they must be followed up to see that they do not get repeated exacerbations. Thank you.